Dr. Lee can
if you
chime in.
Tell me your thought process. Truly speaking, I make this a two-part discussion for any patient that I see with AFib, and I truly phrase it in a very straightforward fashion that an AF ablation is for symptoms, and I do not offer as a way to get them off of oral anticoagulants, and that's a completely separate discussion. If they want to have a discussion about oral anticoagulants, I sometimes say we could revisit that, but if you're having symptoms, catheter ablation is reasonable. Pulse field ablation, I think, will change that a little bit. And also we have newer technologies with percutaneous devices. So to answer your question, I truly never go into that discussion about catheter ablation as a way to get them off oral anticoagulants. Will that change? I think pulse field ablation will change that. And the reason for that is very simple. People who are going for pulse field ablation, the new guidelines are advancing catheter ablation to a much earlier portion of the conversation. The older criteria are basically saying you have to have failed an antiarrhythmic or patient has demonstrated their intolerance. And then you can go down the road of catheter ablation. That is completely changed. That's old dog now. So I think the younger patients, they're not remodeled. The likelihood that they're going to advance and have a higher CHA₂DS₂-VASc score is much, much lower. So we're taking people earlier in the disease process and better outcomes. And when you have better outcomes, less likelihood that you're going to have to keep them on oral anticoagulants. So have I changed my discussion with patients? No. And some patients, obviously, I'll just say, listen, I'm going to put you on oral anticoagulant for a month beforehand and maybe a month or two afterwards. And then because if they're really that low, then yes, that's a very appropriate thing. But this trial actually looked at people who were on oral anticoagulants and said, when do we get them off their oral anticoagulants? And the reason why I love these two trials is now we can actually come to them and say, listen, we do have some evolving data. But I'm happy to.
No, I think your thoughts are pretty much in line with the conversations I had. As you said, catheter ablation is not for getting a patient off of oral anticoagulation therapy. It's really the treatment of symptoms. Okay, and then you do that separately. And really, the two studies that you mentioned were just sort of guideline in terms of giving us some evidence, but it's still patient-specific, and you have to take into effect their CHA₂DS₂-VASc score, how compliant they are. I mean, for me, if patients really want to come off of oral anticoagulation therapy and they're, say, borderline, 2 to 3 CHA₂DS₂-VASc, then basically I have them self-monitor themselves with smartwatches, cardio, something like that. Those that have had strokes in the past, I'm a little more conservative and really lay it out. But then again, it's that shared decision-making process.
So that speaks to the paradoxical effect on both of those trials that you mentioned, that as you continue with the anticoagulation, with oral anticoagulation, you have a higher incidence of stroke, higher incidence of systemic emboli, which is kind of paradoxical, don't you think? I mean, no? Dr. Lee?
That data, when they said stroke, I'm not sure if it was also they included hemorrhage. As you mentioned, you outlined, right. There's, the longer you're on blood thinning medicines, the higher the risk of bleeding, whether it's non-fatal or fatal, or whether it's,
hemorrhagic, yeah,
to the brain or others. So
that was my thought, but then in the Ocean study, they did an MRI. Yeah. So you could kind of tell if it was hemorrhagic or not, right?
Right. That was a nice trial.
Yeah. And in that case, was that hemorrhagic or what kind of stroke? They didn't define it.
Embolic.
They were embolic, even with the rivaroxaban on board.
Isn't that amazing?
But that was a non-inferior. Yeah, I mean, basically they said no difference.
Got it.
Yeah.
So rivaroxaban did not prevent.
Got it. Okay, that's a distinction. Okay, I didn't understand. Okay, and the one other question, I'm sorry, Dr. Klein. So one other question I had, and this relates back to the other trials you mentioned about the pacing.
Oh, yeah.
Instead of biventricular, you compared biventricular pacing with
we call it
conduction system pacing.
So that includes what's called His bundle pacing in this paper and what's called left bundle area which is basically you're trying to target your lead position in a his position, which should engage the conduction system, distally AV node, but proximal to a bifurcation to the right and left bundle, so you actually really get it in the center spot, or left bundle area, so you actually kind of go deep into the septum and actually hit the left bundle conduction. So we put those two together for this trial to call it conduction system pacing.
So you basically, you're speaking to an interventional cardiologist, so we're kind of like, so you're actually mapping to know exactly where you're at, and then inserting or embedding the pacer, the lead inside. Is that correct, or am
So it's quasi mapping. Okay, so what do we actually do? So you go in with a sheath.
Mm-hmm.
You position the sheath based on fluoroscopic imaging, and also we do an injection of contrast. So we kind of want to find where the high septum is, and then actually go forward with the lead. So this lead has the helix already advanced to it. Touch it to the myocardium, and then you start to do pacing. And then you look at the characteristics of the pacing, and basically, okay, this is a good starting spot. So what does that mean? Is that you're actually starting to see some characteristics on a 12 lead EKG that would suggest that, okay, we can now advance the lead, so you mechanically actually burrow this into the myocardium, and every couple turns, I usually do 3 to 5 turns, I then pace again, look at the morphology, and it's essentially, if you want to think about it, Vimal, you want to tighten up that QRS because these people have a conduction abnormality, or you think they're going to pace all the time, and you tighten up that QRS. And you also want to see that as you go from catching the myocardium to actually catching the conduction system, you're also going to see some changes. Why? Because myocardium conducts at a different pattern than actually engaging the conduction system itself. Once we kind of have these preset criteria, and I actually listed on there, but I didn't really want to put everyone to sleep. So you can actually look at these pre-specified criteria and say, okay, this is a good spot. I will tell you, the more strict you are, the more times you're going to have to unscrew it, reposition. His bundle is a little bit different. That does take a little bit more in the way of mapping because it's a little trickier because you have a smaller target, essentially.
More nuanced, yeah, more technically difficult.
Yeah. So the beauty of these new leads are, number one, they're a little bit easier to work with, and basically if these leads do what they're suggesting, you can actually even maybe have one less lead going to the body.
That's
Now,
cool. It's really good.
Having grown up when there were all these device complications with stripped down smaller leads, it predated me a little bit, but I kind of came along after this in the tidal wave of all these lead complications. It does give me pause about a smaller lead, but
The smaller is better, and I think Dr. Lee and I have a patient in common right now that we're dealing with severe heart failure, and I'm just thinking about this particular modality, instead of putting in biventricular leads, maybe put in the pacing, conduction system pacing lead instead. It may offer better improvement. And she can't even tolerate goal-directed medical therapy off of the biventricular pacing because they had to turn her biventricular pacer off because it was the lead was loose and it was shocking her incessantly. So then they had to actually turn the thing off, and now she's functional class 1, but she has an EF of 30%. And if you just basically go a little bit up on her core egg, she gets syncopal. So I mean, we got nowhere to go with goal-directed therapy at this point. So it's all on Dr. Lee now to help us with this one.
Those are my colleagues. I no longer do IVs.
Yeah.
But
it's an interesting
it is.
case. It might be a good application for this particular.
No, I think
device.
Most people like the data you presented. It's showing equivalent or superiority, and just from think of lead extractions, things like that, one less lead. This is much simpler, safer to do, and a lot of times you can't do biventricular pacing.
Yeah.
The failure rate is 10%. Because the veins are positioned. So, I mean, this physiologically makes a lot of sense.
What about in the patients with not as wide QRS? It still applies, right? The same criteria applies. So you like if you have a QRS complex less than 150 milliseconds, you're not going to be doing the conduction or the conduction system pacing, right? Yeah.
So it's all the same criteria.
Same criteria.
apply.
Okay. Dr. Kalina, you have a question?
He's like, I'm worn out.
I'm over.
He's done, okay.
I had there's no reason.
Uncle.
To speak.
Well, listen, thank you so much, both of you. Yes,
I have a question. Yeah,
Yes, yeah.
It's commentary mixed with what
Dr.
I'll give you some-
Dr. Ross, yeah.
So, I'm a general cardiologist, and I had a psychologically traumatizing event. My second month in clinical practice, which was that I was following guidelines. I saw a 37-year-old with paroxysmal atrial fibrillation of low burden on an MCOG. His CHA₂DS₂-VASc score was 0. And so followed guidelines and did nothing. And not very long after that, clinical decision was committed. The patient embolized to his posterior circulation and went cortically blind. And no one could explain it. It happened, and it was probably the worst thing that could happen to somebody coming right out of fellowship, because it just like shattered my confidence in the CHA₂DS₂-VASc score.
Oh, yes.
And it's made me like a freak amongst my partners, because I've been doing crazy things that are definitely not supported by guidelines in this arena. Like, I will offer young patients with CHA₂DS₂-VASc scores of 0 off-label access to DOACs, just because that has freaked me out so much.
Yeah, totally. Mm-hmm.
And I think maybe I just had bad chi or something, but like I've had horrible luck with Watchmans. I have like probably 3 or 4 people in my practice, not DRTs, but have had like, outside of the appendage embolic events, despite beautiful TEEs with complete closure afterwards. And so they're all on belt and suspenders now, because, they were in that 10% that originally got citation. It's like, I have the worst luck. And then the worst thing I could have done to feed my paranoia, right, is that I started putting loop recorders on the myself.
Oh,
See that everyone, and you just see these people that have like 18 minutes of AFib and then nothing else, and the report reads like, less than 1%, or, some of these don't even flag above threshold, and it's like, oh my God, this guy had, 30 minutes of AFib. Yeah, so I put all that together, and it just really scares me. And then you see trials like this, where, not a knock on you, but the EP world and the literature is so obsessed, all of cardiology is so obsessed with composite endpoints, and it just feels so disingenuous. I mean, I think we can agree that, generally, cardioembolic protection and bleeding, are kind of different trains that go in opposite directions. It's almost like we've falsely, made them equivalent. And to me, in my world, perfectly purely an opinion, but stroke is terrible. It's disabling, it's disfiguring, but non-fatal major bleeding is ipso facto by definition non-fatal. So I mean, that's bad, but you're still alive and you're not paralyzed or cortically blind. And so when they composite these endpoints, it's no brainer to me. If you stop Xarelto, obviously they're going to have lower major bleeding. But to say, this is a great idea, I'm just so afraid people are going to take that ball, and there's already, and obviously good to hear that you guys are not 2 of those guys, but there are so many John Wayne, like John Rambo, whatever EPs out there that are using the promise of getting off DOACs as sort of like a hook to get people to, and it's so ethical, I think. That it's just out there in the community, and I think it really has a chance to. I mean, if you could convince me that a pulse field will absolutely take your stroke risk off the table, stopping anticoagulation, I think it's a really dangerous business, more than people realize.
And also, I think
the question is, after I just said that, how paranoid do you think I am?
No, I think your concern is very valid. I mean, it's one of the hardest discussions, to have with the patient, and that's why it is a shared decision making. You can present the data, and the data that Dr. Donaldson presented is just more that you can say, tell the patient. But ultimately, you're going to have risk takers and non-risk takers in terms of patients. And when I say risk, it's a graded risk, right? And that's sort of what we're trying to do, is give them some guidance, because nothing is 100%.
Yeah, this is the dilemma that you're going to deal with, and I think if you're going to follow up these trials were how long each one for what was the follow up?
2 years, 2 and 3 years.
Yeah, so I mean, I think if we get into the 5-year, hopefully they'll follow it up. I don't know if they're going to follow up for 5 years, but if they do, it might be interesting. What would be the difference? Is there any difference in terms of the Kaplan-Meier curves? Will they will they widen, or what will happen?
Yeah, I think to your point about the injectable loop recorders, because that's like getting married, right? I mean, you're wedded to this patient because now they have a little chip with no secrets.
And they get a copay every month.
Yeah, every 30 days. For that benefit.
With your name on the bill.
Exactly. But I think the interesting thing is in some of these trials, so one was performed in South Korea, the other was in Canada, so they have different healthcare systems. What do they define as a successful catheter ablation? And I think that's where the money is on your 37-year-old who had a stroke. So, like, why does a 37-year-old get a stroke? Why does a 37-year-old have AFib? So these are unanswered questions, but I think the tricky thing is I share with you the concern that people read the summary statement that if you get catheter ablation, you can come off your oral anticoagulants. And that is not true. That's not what these trials show. So I hope I did that big,
Mm-hmm.
Oh, yeah.
Disclaimer.
You did, but
speaking to the microphone.
Yeah.
Yeah.
Just afraid Medscape or Doximity will take that headline and start pushing it to the masses, and
Yeah, absolutely.
the general practitioners of the world will get a very false, multiple very false sense of security.
Yep.
Yeah, it's a nuanced decision.
It's nuanced, but
It's a critical. Yeah.
Because you stop
Not so nuanced.
Thank you so much for the discussion.